I would love to invite to the podium now John Sodden, who will be presenting for the Ontario Working Group. He is Special Projects Director and Public Education Patient Advocacy at the Cardiac Health Foundation of Canada. And from Quebec, we have Eva Villalba, the Directrice Générale de la Coalition Priorité Cancer au Québec, and Ella Amir, who is the Executive Director at AMI Quebec.
So good morning, and thank you. Our working group fragmented and kind of disappeared. So we have the largest population-based province, should have the largest committee out there, and we had the smallest committee whose times were all over the place and really couldn't commit to sort of getting together. The two who finally got together was who else but Louise and John. And about a week and a half ago, I panicked because we were starting to miss all of these phone connections and reached out to numerous associations to say, what are your patients' top 3 health priorities? And I want it from a consumer or patient perspective as opposed to an agency perspective. So I got some feedback, and that's kind of how we've developed the list that we have here. But there's a lot more out there, and some of the things that I think we get caught up in, even with patient advocacy, is that oftentimes we're speaking on behalf of the agency, and some of the issues for the agency are different than the patient issues. So it's really good to hear coming across the country some of that patient perspective this morning. The major issues are cancer in seniors in Ontario. And I'll elaborate on these when we look at the things that contribute to them. Drug shortages, chronic conditions, mental health and addictions, and rising vaccination refusals, denials as a major process. My screen here I miss a little bit. So in terms of cancer, we have increased rates of cancer. Recently, CARP actually just did a whole focus group and a series of studies, as well as a survey on cancer. And one of the things that they discovered is that 1 in 2 of us will develop cancer in our lifetime, and that 1 in 4 of us will die from it, and that 90% of those experiencing cancer now are over the age of 50. So when we think about the baby boomer impact as we're in the midst of it, and I'm one of those, it's massive. So the projection is that there will be a 40% increase in cancer rates in the next 10 years. That's massive for a system that's struggling already. Cancer patients are now waiting more than a month for initial treatment. Notwithstanding, we identified the whole issue of diagnostics and when does that happen? And how often does it happen so late? And many of us have stories of neighbors, friends, family members who, when they finally get diagnosed, right, they have metastatic cancer at stage 4, and we're treating multiple issues. And I have that experience currently with a neighbor. Drug shortages, 1 in 4 Canadians are currently impacted by drug shortages in Ontario. This is massive, and it's going to get worse. Currently, over 2,000 drugs identified as either unavailable or difficult to get. And emerging issues are access to drugs themselves. That's going to be a huge issue as we see the PMPRB changes coming up in the new basket. In the U.S., the U.S. FDA has just identified that sterilization is an issue because of a chemical that they're using. What that's going to lead to is more and more shortages of particular surgical instruments, including a delay in surgeries. So it's something for us to start to have a look at. CMA surveyed Canadians, and in Ontario, the response was that 48% have a negative view of healthcare in terms of the system of delivery, and equally, those 48%, I think it's 46%, are concerned about the cost of medications and access to medications. So it starts to tell us that there's a huge number out there. Chronic conditions, for number 3, 1 in 3 Ontarians are living with a chronic condition. 80% of those are over the age of 65 and they have one condition. 70% of those have at least 2 or more conditions. So this is a major issue that's impacting on everyone. Currently, there's 35,000 individuals in Ontario on the wait list for long-term care. And on a daily basis, there's 2,100 of those sitting in hospitals, occupying beds that could be freed up. So the whole issue of hallway medicine. In terms of mental health and addictions, Deloitte just released a study on Friday, I believe it was, that 50% of Canadians miss work due to mental health issues, costing $50 billion annually. That's massive when we're talking about how do we save money. Increasing demands on systems from adolescents, seniors, Indigenous people, and refugees. So it's starting to overload the systems. In terms of vaccination declines and refusals, 38% of students at an alternate elementary school are not vaccinated. This begins to raise huge issues, not just for those families who choose to not engage in vaccinations, but for those of us who are aging, those of us with chronic conditions, rare diseases, then we start to become at risk. So it becomes another major issue. This morning, I don't know if anybody had a chance to listen to CBC, but when we talk about cancer issues, and what was raised earlier was the whole issue of data and access to data. This is a woman who just did a study on Black women and having health statistics on Black women. The incidence she was looking at was breast cancer and cervical cancer. In Canada, we don't have separate stats for Black women, which means it's a whole issue that's been ignored. For some of us who did some work in schools around ethno-racial groups and the changing diversity of populations, this is a major issue for us with all groups. How do we start to look at who's out there? And then as we look around this room, does this room actually reflect Canada and the changing mosaic in Ontario? And if it doesn't, how do we get people in this room? They become major issues. So some of the strategies to address health issues. Holistic strategies needed across the continuum of prevention, diagnosis, care, treatment, support, palliative care, and end-of-life care. What we really need in dialogue with Louise is a rare disease strategy. These are genetic-based. We're talking about specialized medicine and approaches. So maybe the strategy needs to be much like the one in the US, where we have a special strategy and treat cancer as a rare disease. Chronic disease, chronic conditions need a holistic approach to chronic disease management. And part of that, we heard the strength of that was the CHCs, and I would suggest chronic disease hubs with access to centers of excellence with specific disease areas. Mental health and addictions. Michael, who was on the committee, shared some pieces with me in terms of CMHA's Ontario's focus. And the 5 areas that they looked at were access to standardized core set of mental health and addiction services. Core services should be seamless across the lifespan and available in each region in Ontario. Core services should focus on enhancing mental health, substance use, and addictions treatments for all Ontarians. And we're running into the same issue as you go to the north. It's lack of access to services, and how do we create those kind of hubs and access. New investments for data infrastructure to enable health quality improvement. It's not there in mental health. There's been tons of initiatives over the years, and I think still disjointed. A key step is to invest in a data strategy for an entire community-based mental health and addiction centers, and one that lends itself to speaking to other systems. Direct investments in housing, so the Homes First strategy, how do we make sure that people are housed and then can be treated? Enhanced integration of primary care and mental health and addiction services. so that service providers are actually serving those with chronic mental health problems, and expansion of mobile crisis intervention teams. And the final one, lack of vaccinations, more public health education, and stronger measures related to the refusal to vaccinate. And anybody else who's here from Ontario in a specific group who wants to add areas that we haven't identified. We tried to keep it to 3 and we expanded to 5, and we could probably continue this process. Yep.
Thank you. It strikes me how somewhat different each working group has been presenting, and it's probably a reflection of the complexity of healthcare in Canada, and I would add to it, because what we have decided, I was very clear about what I'm willing to report and what I can't report, so we have agreed that I will speak about mental health in Quebec, and Eva will follow me with description of physical health in Quebec and with a summary of our slides. But to make it even more complicated, I will make some comments about general healthcare in Quebec, but my observations refer mostly to my experience in the community, in a community-based setting, mostly with working with families affected by mental health issues. I am in no way an official representative of Quebec. My experience is anecdotal. So while I'm, providing this disclaimer, I have been working in mental health for so many years that I don't also belittle my observations. Since the 1980 in Quebec, like many Western societies, has seen the cost of funding in public healthcare systems skyrocket. The situation is due essentially to the aging of the population, overconsumption of healthcare services, the cost of medication and new treatments, and we have heard about it a number of times yesterday, and the continual need to upgrade facilities and equipment. In the late 1980s, the Quebec government began reorganizing the healthcare system by shifting to ambulatory care in an effort to cut spending. Some healthcare institutions were closed or amalgamated, while others were assigned new functions. The transformation of Quebec's health and social services system has resulted in the transfer of responsibilities assumed by the state to other social actors, including the sick, their families, and the community sector. Part of this transfer, the outpatient shift has resulted in a reduction in the length of hospital stay for several clienteles, resulting in an increase in home care services provided by CLSC workers, community groups, private firms, or by the sick person themselves and their relatives. Within healthcare, mental health has also seen changes. The 90s virage ambulatoire that was adopted in Quebec in mental health was a great vision that was congruent with the increased recognition that people with serious mental health challenges should be given the opportunity to live in the community and receive the support that they need. However, the plan has not been followed by proper resources that were needed when hospital beds were closed and patient care was transferred into the community. So again, I think that it's a good example how practice doesn't follow policy. I think that we do sit around the table when policies are being designed, but this is not a guarantee that practice is going to follow through. The failure to provide proper resources in the community resulted in an increased burden on community resources and on families. Fast forward to 2015, when a major restructuring took place that put many healthcare institutions in the province under one roof. Budgets were cut again in an attempt to control costs, and the reform presented serious challenges, even though it was again in the name of improving access and continuity of care. And I have to say that I was envious of Ontario CHC, initiatives. I think that embedded into our policy is also an attempt to create general clinics with multi-actors, but this is not even remotely close to what I'm hearing about CHC in Ontario. At the same time, the government launched the Mental Health Action Plan for 2015-2020. This is, again, language speaking. It's a progressive plan that speaks the language of recovery, and this is really the language that we have been talking when we talk about mental health. Engagement with greater emphasis on adequate response to diverse needs of individuals who use mental health services, as well as the improvement of practices. It focuses on combating stigma and discrimination in the health and social services network, and calls for a greater participation of service users and their families in the planning and organization of services. And I should also note that mental health has been the orphan of healthcare for many, many years. And just as a point of interest, in 2007, when the Mental Health Commission of Canada was created, Canada was the only G8 countries without mental health strategy. So in that light, the question is whether mental health services are better, same, or worse. And again, you may hear different options. Again, if someone here from the government or from the public sector would share their opinions, it would probably be quite different from what I'm telling you. So it's your choice, who do you want to believe? 4 years after the reform, it appears that in mental health, the reorganization of the system has created a lot of chaos that resulted in an exponential increase in the number of patients' requests. This is also reflected in the experience of families who have a hard time communicating with medical practitioners. Medications are still the treatment of choice in Quebec mental health care. And again, mental health, unlike some physical illnesses, should not necessarily be relying on medications only, but there is still a very strong reliance on medications. But with budget cuts and the overall of the system, practitioners have little time to do anything beyond prescribing medications. Community organizations complain that they bear the brunt of these changes and are not provided with proper resources to address their needs. So my experience suggests that mental health care is still a challenge in Quebec, given that mental health permeates many conditions outside of the mental health sphere and potentially all levels of care in the entire lifespan. And given the already recognized increase of depression and anxiety in society today, if we wish to address this issue properly, we would need an honest evaluation of societal values and priorities. And in the interim, until we do that, the following could help. Better collaborations within the healthcare system and with outside sectors, a bigger chunk of the research funding pie assigned to mental health, a growing emphasis on a whole person care, and a greater attention to increase resilience in children and youth. And before we do that, I'm afraid we cannot expect a dramatic improvement in mental health care in Quebec. And lastly, if I may humbly, to suggest that as we consider patient-centric reform, maybe we want to replace or at least add the description of whole person care. I think that patient-centric focus has, to me, in my mind, and maybe not by coincidence because I'm coming from slightly different perspective, a very medical base view. And I think that we have been talking about a number of times about relationship with indigenous communities. I think that it is important across the board. We are talking about a holistic and more humane perspective. It seems to me that whole person care catches this much better and does better justice to our efforts and to our attempts to change the system. Thank you.
Hello again. So I'm just going to summarize a little bit because I like visual supports. So Ella spoke about, in general, what happened in the healthcare system. That virage ambulatoire that she was talking about was basically like a big deinstitutionalization, but it happened everywhere, even in physical health. There was really these things called the les guichets uniques. It's like you can only go into the system in one way, and then after they send you out. That was a big adaptation. Also, the creation of INES in 2011 really changed the way that we accessed medications. It used to be really bad, like 5 medications were available in the rest of Canada, and we got like 1 for kidney cancer. It was really problematic, so that was a big change. And then Ella briefly spoke about what we call the Réforme Barrette, which I could have just replaced with like a big wrecking ball image, and that would have been good. This is just like very simply like the big drastic change in a couple of numbers. It was traumatic for the system. It took us like 2 years to get over it. Everything stopped. It really traumatized the workers in the healthcare system, and there was no change possible. There couldn't even be any positive change because they were just trying to deal with these major changes. And I think the problem was not so much the intention of the change was not bad in and of itself. It was like a simplification of too much bureaucracy and kind of like, simplifying the structures. In principle, it was okay, except that there was 0 consultation, and it was literally like creating foie gras. It was like stuffing something forcefully down the system's throat, and it was just a catastrophe. Everybody in the healthcare system and outside the healthcare system agrees. We were stalled for 2 years. Luckily, now we're out of it. So now there's time for positive change, but there's still this allergy to structural change. Luckily, the things that we're proposing are more optimization questions and solutions. And so we don't want to create or destroy structures so much as we want to optimize the system, increase access, better use resources. And so my slides are on the left, and I still made a little resume of Ella's points as well on mental health. So in general in Quebec, things have gotten better. We've done a couple of patient surveys. My organization regroups about 55 organizations across Quebec, and we do try to talk to other people. And basically, the consensus is once you're in, you're well treated. Like, people love their nurses, they love their doctors. It's the getting in that's hard, right? So it's really like the primary care, and we did hear about this in other jurisdictions. So accessing primary care is a problem, and having early diagnosis is really a problem. And so there's a shortage of family doctors and nurse practitioners. I was on a waiting list forever and ever to get a family doctor. It's really a problem, which I'll talk about that later. And nurse practitioners were starting, but it's just starting. I'll talk about that later as well. Difficulty in navigating the healthcare system. So the healthcare system is already super complex. If you speak French in Quebec, maybe if you speak English in Montreal, but if you don't, it's pretty hard. So like immigrant communities, we have major problems with actually accompanying Native people. I thought that the idea of an Indigenous navigator is brilliant, and I really would love to know more about that to see how we can maybe encourage that in Quebec, because I really doubt we have it. I've never heard of it for sure. Diagnostic tests for precision medicine are the access is a problem. So now we're getting to have access to all of these really interesting medications that are for personalized medicine, but the diagnostic tests are still a challenge. And often we have to go outside of Quebec, even to the United States, Boston usually, or California, to do these tests. And it's really creating a delay, and it's really a problem, but we do have the expertise, so it's really a shame. So that's an issue. And then inequitable access and delays to obtain medication. So there's 2 main issues. One is regional inequities. So even though the medication is supposed to be available, if you live in a remote area and that hospital doesn't have it, or they don't have the budget to give you this expensive medication, they'll just say, sorry, go to one of the major centers. And if you don't go, then you don't get it. And that's a regional inequity. If it's allowed, if it's reimbursed, it should be available everywhere and not according to your postal code. And then reimbursement issues, I'll highlight that, but there's issues with, it is supposed to be available, but can you actually get access to it? Is it reimbursed or not? I'll talk about that later. And Ella addressed some of these issues. Growing demand for mental health services, timely access, difficulty of families communicating with healthcare professionals, and community organizations, and lacking resources. So in terms of the top healthcare barriers, a lot of people have mentioned there's insufficient nurse practitioners, nurse navigators, and GPs coming out of university. Those that are, like nurse navigators, especially what we call les infirmières pivots en oncologie, so the nurse navigators specifically in oncology, are a godsend. Like the patients say that is the single best thing that they love about the healthcare system. These nurse navigators that serve to coordinate all of the care and really see the person as a whole, refer them to all of the services that they need, but they're few and far between, and they burn out because they're overworked and they have too many patients, and they really get extremely invested, of course, and so we're really having a problem retaining them, and so we need to train more of them. The diagnostic tests, currently we're having an issue where the medication is approved, but the diagnostic test is not approved, so there's a misalignment, and it makes it really hard to do that, and like I mentioned, you have to go out of province to get that, usually in the US. And then in terms of access, there's some outdated bureaucratic processes that limit access to medications. We did see that Ines is trying to speed things up, and we're very happy about that. But the hospital pharmacy budgets right now, like I mentioned, depending on where you are, the hospital pharmacist will decide if that hospital has the budget to give you this medication or not. And that, to us, does not make sense, and it's a problem that needs to be addressed. I think it worked in the olden days, but now we need to adapt our system. And then the issue is actually a lot of patients come to us and complain that there's a delay between the time that Ines says, sure, this medication is great, we recommend that the minister looks further into it and inscribes it into the reimbursement list, but between the time that the negotiations take place and the drug is actually listed for reimbursement by our public system, there's a delay in which patients sometimes don't get access. And if you're talking about advanced metastatic cancer, you don't have time to wait. You don't have a year. And then you have to disperse out of pocket, and so that's a serious problem. And then in mental health, Ella spoke about the fact that practitioners have little time to do anything else besides medications, that psychotherapy and other therapies are often not accessible in the public sector. So there's long delays. If you want to pay out of pocket, much faster, but otherwise in the public sector, there's a delay. Community organizations face important challenges and not enough research funding. In terms of research in oncology in Quebec, it's actually really, really improved in the past about 2 years. We've had a strategy on life sciences that really helped to promote Quebec as a clinical research center for oncology, so we are happy about that because we were lagging behind before. And then in terms of solutions, so obviously increasing access to primary care diagnosis. We do have good news on this front. The current minister, who I lauded yesterday, the social worker, she's really into reinforcing first line workers. And so she's come to an agreement with the Order of Nurses and the College of Doctors, Collège des Médecins, to delegate more acts to nurse practitioners. So I believe that Ontario was advanced on this nurse practitioner front, and so we basically tried to, adopt those best practices. So it's fresh from about like a month ago. So the minister did come to an agreement. Nurse practitioners can do way more acts than they were able to do before. So we don't have those amazing clinics that you have in Ontario, but we have these, they're called GMFs, and it's like a kind of family medicine first line kind of clinic where you have family doctors and nurses, and you can do a little bit of that first line, but it's not as good. We really want to go to where Ontario is. But in terms of nurse practitioners, they can do more, and now pharmacists can also. They're also working on it currently to delegate more acts to them and to get people out of the hospital if they don't have to be in the hospital, and more in first-line care. And then there is still a concerted effort to, we call them, I think this is a bad translation, but we call them orphaned patients, les patients orphelins. It's people without a GP. I know I have to explain it, but I was an orphan patient for a long time. And that's a problem, because you basically end up in the emergency room because nobody's doing your regular primary care. We really need to pressure more for increased spots in university to train more family doctors, nurse practitioners, and nurse navigators. Part of the problem was that the incentives, especially for family doctors, were not great, and so they're working on that. In terms of diagnostic testing, we have amazing expertise that we don't want to lose to Ontario or anywhere else, or the United States. We do have really great clinical centers that are capable of doing the pathology and the diagnostic testing, biomarker testing, genomic testing. But they don't have the mandate and the resources to do it currently. So that would be a potential solution, is to actually repatriate all of these tests that are being done elsewhere and also keep them within the academic setting or the hospital setting, instead of making them go private. And then finally, in terms of modernizing the access and processes, the HTA evaluations, like at INES, are already considering value, which we encourage them very strongly to continue doing. I did speak yesterday briefly about the reform of our hospital financing. So it's not adequate to do financing of hospitals based on a historical basis. It really needs to follow, the actual workload and the resources, the necessities of each hospital and community. In terms of, we really need to find a solution to shorten and to create immediate access. As soon as a medication is approved or recommended, then patients should have access, and then the negotiation part can happen after, and the government and the manufacturers can just, talk amongst themselves and figure that out. Like, patients shouldn't have to suffer while there's a bureaucratic process happening about pricing, like nobody should have to die in that interim. That's just unacceptable. Sorry, I get very upset about that. And in terms of mental health, we did have the Association of Quebec Psychiatrists come out recently and do a big media round with a lot of emergency room doctors also this summer that were decrying this problem of young people, like really pediatric cases, like below 14, showing up in the emergency room with like anxiety and stress. And so there was this, the Association of Psychiatrists said that we really need to, they suggested, it's called Alpha Connecté, and it's very interesting. They're proposing to have resiliency education, resiliency training in elementary schools to teach children better emotional and psychological coping skills. And so that's a very concrete way of addressing a real need. There's also a recognition, one of the solutions would be a recognition of the importance of non-drug therapies and increased public coverage of, for example, therapy. Increased support for community organizations in mental health, and significant research and necessary funding dedicated to mental health. So in conclusion, what we realized in talking is that physical and mental health are like in two different silos, and I wasn't sure if that was only in Quebec or elsewhere, but I have a feeling it's kind of across Canada. And so when you're being treated for mental health, you're not being followed for all of the physical symptoms and problems that you actually have, and vice versa. When you're being treated for cancer, you're not being adequately referred or diagnosed for the mental health issues that you may have and your needs. And so there really needs to be a better integration of that, and a recognition that mental health is transversal across all phases of our healthcare system. And so, non-surprisingly, I think that the main solution is value-based care. So in a value-based healthcare system, it would really be whole person care, putting the patient's needs first and their health outcomes, which include physical and mental and social elements, at the center of policy decisions. And the system structure, that would affect the system structure without actually changing it, but it's more of a cultural shift. So we're talking more of a paradigm shift that's necessary and not breaking and creating new structures which everyone is allergic to. So value-based healthcare is the solution. Thank you very much.
Hands up.
Hi again. So back to Ontario for a second, John. I just wanted to speak a little bit about the issue that you talked about briefly, the U.S. importation of Canadian medicines. Louise was asking earlier, what can we do right now? I mean, that's an issue that we really need to be dealing with right now, because there are lots of U.S. states that have passed legislation to allow bulk purchasing of medicines from Canada to meet the needs of their patients. Florida being one, which has almost as many people as Canada. Yeah. They would take our medicines very quickly, and there is no incentive at all for the industry to resupply the Canadian market if they're cannibalizing the U.S. market. So what we can do is we can demand of the Canadian government that they take very concrete action to prevent the U.S. Distribution system from purchasing medicines intended for Canadians. So just want to put that out there. The other thing is that you mentioned the need for a national rare disease strategy, and I just want to refer you to the Canadian Organization for Rare Disorders proposed strategy that was developed in 2015 or 16. That's already been developed with considerable sort of patient input to the development of it. And if we're looking for one to sort of hang our hat on, it exists. So let's just move it forward. Thanks.
Thank you. Okay. I'm going to make my way around the room. Is it okay?
Yeah, thank you. One of the things that we've heard that Quebec does incredibly well is your provincial pharmacare system. You have a mixed model, and it's been hailed as a potential solution across the country. I'm sure everybody is aware that with the arrival of a new government, there's renewed vigor to have this national pharmacare plan, which we need to be aware of that the devils are in the details. And the model that is currently being proposed would be a single-payer federal model. And Quebec has already stated like they would opt out because they have a system that they feel is optimal, which is a mixed model. So I'm not sure if there is a question in here, but what I wanted to also note is that when we look across the country and we're doing a regional view of what are the barriers and challenges in our system, that each of the provinces have these models that impact us all federally. And we didn't talk about it in BC, but they have one of the most restrictive access to medications models across the country. Reference-based pricing is one. Most recently, they had a restriction on to a biosimilar drug, so that removes patients' choice. And we all just need to be aware that these policy decisions that are being set regionally have massive, massive impact for all of us across the country. And the devil is always in the details. So I know one of the previous speakers referenced, we're one of the only countries around the world that that doesn't have a mixed model, but we do in pharmaceuticals. And if in the new model, that would be potentially removed. So it would be just the government, and it would be an essential medicines list, which, let it be known, that essentials medicine list is going to be very much smaller than what it is now. And there are access challenges to what we have now.
I could kind of speak to that briefly, and I don't know if you want to, but in general, the consensus of the general population, and there are exceptions, and I'm sure Cheryl Ann will want to address this. That's why they're probably giving her the mic. So she can give you her opinion because she's had a very specific experience with it. But I would tell you that in general, the population believes that we do have the best model in Canada, and we do not want to participate in national pharmacare if it's going to mean having less access than we currently have. Because I think objectively speaking, nobody truly falls between the cracks in Quebec. Like everyone is covered, maybe not, there's still out-of-pocket expenses and there's still issues with reimbursement, but nobody is really falling between the cracks. And I was actually super surprised to learn how in the rest of Canada there are people that are totally uninsured. That is mind-boggling to me. So we would not want to, and this is the government's official view, they do not want to participate in national pharmacare if it's not better than what we currently have, and it's guaranteed, because you can say it's going to be good, but we don't. So there's definitely an opt-out option from the government's point of view, and in terms of the general public, there's no interest in changing. Like it's kind of working well for most people. But I'm sure Cheryl Ann will speak, because there are some important considerations. But in terms of, what's the best that we have across Canada, we kind of do believe that we have the best. It could be better, but we wouldn't want to have anybody else's coverage.
So, yeah, I wasn't going to specifically speak to that, but I'll just say, yeah, I'm happy I live in Quebec on my $4,000 a month drug. I love the way our system works. Where it falls down is the reliance on insurance in some cases, because it's unfortunate, but I'm not going to debate this real long with everybody here today, but it's unfortunate that sometimes insurance companies do share information with your employer, and that's where I have a problem, because I would like it that my health is my issue, and it's not something for discussion with my employer. And so I've actually had to help people find other jobs so that they can get lost in bigger companies and not stick out like a sore thumb when you're taking very expensive drugs. But my point was, I was really listening to what you said about Ontario, because I think we really better step up and pay attention to the vaccination issue. Because if we don't understand the fact that somebody decides not to vaccinate their kid today, that is a real travesty. But the problem is, it's coming from a place of mistrust and fear. It is mistrust of government to regulate medicines. It's mistrust of the pharmaceutical industry to do what's right and to make safe medicines. We have to be very careful about that, and we have to take some ownership on how do we educate people, because this is just going too far. Because now if you've got this whole younger patient population out there, mistrust, disengaged from government, mistrust, disengaged from the pharmaceutical industry and doctors and healthcare, we have a crisis in the making. For people like me who survive a really deadly disease and are immunocompromised, it'd be a shame that I found the things to save my life only to be killed by measles. This is insane. This summer in Quebec, in the area of Montreal, there were 7 cases of measles. Do you know how many people had to not go to work and had to self-report because they were at the MUHC on a certain day at a certain time when somebody came back from the US and was later diagnosed with measles cases? It's the terror it caused young mothers, and it's just, no, it's a crisis in the making. So I think all of us have a lot of work to do on that one. So that was my major thing, because it's that we have to address that mistrust of government and healthcare.
You were talking about, you were totally surprised that some people don't have insurance.
Yes.
I'm one of those. I did have insurance through my workplace. But when that was sold to Air Canada, a few years later, all of a sudden Air Canada told me that, no, they were canceling all the retirees' insurance policies because it wasn't beneficial to them anymore. So my insurance was cut when I went to get new insurance, private insurance. I was told, well, that wouldn't be covered anyway because it was a pre-existing illness. So somewhere we have to work with industry to somehow allow us to get something to cover us. I can't get insurance for my life at all because of my pre-existing illnesses. And if I go to work for somebody, which I've done, I can't get insurance due to pre-existing illnesses. So something like it doesn't work, and to have a government drug plan that is not going to cover my drugs anyway. We need, like, that's where we need to work with the pharmaceutical companies directly, because right now, that's where I get my help. My government is not going to approve my drugs. And I know that because it's way too expensive.
I'm just speaking from the melanoma space now. We see all these different access issues across the country, and it concerns me. We got the biosimilar access issue in BC, which I'm worried will start a precedent across the country. We've got the access to orals in Ontario. That concerns me from the melanoma perspective, because will that end up hurting the rest of Canada? So I have huge issues about what's happening within the country, specifically provincially. So our top 5 issues are probably the same. We can't get access to a GP. I have stage 4 malignant melanoma. I couldn't get in to see a derm to save my life. I traveled to the US. But what I do want to say here is I want to go back to Quebec in the melanoma space, because you really have become our gold standard in the care that our patients are getting. And I think we can learn a little bit from that, and I think we need to showcase that a little bit. And I know my oncologists, every time I get wound up about this, they're like, oh, Cathy, leave me alone. That was a really bad accent in French. Really bad. I should have tried Scottish. I'm better at that. But they do. They say, please just leave us be, because we're doing it right and we don't want to ruin that. But I think there's really good opportunity for us to be sharing that best practice. I really do.
Thank you. Oh, we have one more. Okay, so we're running a bit late, but honestly, this is the presentations and the conversation is so rich. I'm not pulling out cards. So, and we have a little more breathing room today, so we'll just make it up. No problem whatsoever. Please.
Thank you very much. Since the issue of the vaccination in Ontario came up, I just thought I maybe touch upon that. When it comes to vaccination and access to vaccines all across Canada, the inconsistencies is even more prevalent. As you know, like we know that NACI evaluates the vaccines and all that, but then each province, they really play their own game. For instance, Quebec, I agree that it has the best mixed model system, but when it comes to vaccines, for instance, Quebec is one of those few provinces that does not have a universal vaccination system. Like for instance, for flu vaccine is only accessible for, population at risk. And so this is something that I thought, I know that the point of vaccination was not brought up before, but since, for Ontario specifically, we brought it up, I just thought that I'd bring it up. Thank you.
We are trying to encourage them to vaccinate, for example, more vulnerable populations and expand that and facilitate that as well. There is, right now with I briefly touched on the delegation of acts to pharmacists, so we're working on getting pharmacists to be able to actually give the vaccinations, and that would be huge, because right now people have to go to their GP to get it. It's ridiculous, and so or to hospitals, so it's much better to get it just directly from your pharmacist and not even to have to pass through a nurse practitioner, because we know that elsewhere pharmacists are able to do that, but we don't have a very we don't have an official vaccination program, and we fought really hard to get the HPV vaccinations in schools and then to have that expanded as well to boys. There's been changes and we're not happy, but we're always following that really closely. And I think part of what's great about these conversations is, learning best practices and trying to mutually influence each other across territories for the best things and learning from each other's mistakes and the worst things. Like, for example, seeing this, anti-vax problem in Ontario, which does exist in Quebec, but to a lesser extent. And so we need to combat that before the contagion spreads, I think.
Pun intended.
Pun intended.
And John had one more comment.
A druggist being able to give your injection isn't always a great thing, because you walk in to get your medicine, the doctor or pharmacist goes, you haven't received it yet. We can just go in the back room and give it right now.
Yeah. I know, but that's a valid point, but the advantage is that it's much more convenient to people to go to their local community pharmacist than to go to the hospital or...
But remember, you're going to get them buggy.
Yeah. And I would just bring up another point that I think might be interesting, because somebody spoke about insurance. It's more in the oncology space, but our coalition is looking to reactivate a law project, a projet de loi, a bill, I guess, in France, they have this thing called droit à l'oubli, so the right to forget. And basically, if you've had cancer, especially if you've had young adult cancer or whatever, even just a cancer and then it goes away, and you're happy and it's 5-10 years later, it's still difficult to get insured. But in France, they have this thing called le droit à l'oubli that forces insurance companies to kind of wipe the slate clean and then make you insurable again. And so we actually worked with one of the opposition parties to get that project. It exists. We're going to be reactivating it again in 2020. So we'll keep you posted, because, maybe we can encourage other provinces to do that. And I mean, it is only like a portion of the population, but maybe it does have other applications. So yeah, we're going to be working on that, and we'll keep you posted.
There was one other piece that I didn't address, and that was caregivers. So as we're seeing the expansion of cancer, prevalence rates, as well as chronic disease, in Ontario, many caregivers are burned out, stretched to the limit, and we have a really poor way of reinforcing care and providing for income while they're providing that care. So they're getting stretched to the limit, right, and can't provide care any longer. The Ontario Coalition has recommended that we have either refundable tax credits or some other way of supporting people while they're on leave and doing caregiver roles. Mm-hmm.
So I want to thank all of you, panelists and participants. And I want to end with what's on the screen here for a moment, because it's so easy to feel overwhelmed, and with all of the different issues and all the different provinces and all the different aspects of our very complex and convoluted systems with quotes around them, because systems usually should connect and work kind of like nature until you break them, and then they don't. And so I just want to end again with the opportunity. It's the reason why we introduced the concept 3 years ago of value-based healthcare, to recenter and rethink and reprioritize. How are we planning, the whole spectrum of health systems in our provinces and federally, by putting patients' needs, values, and outcomes, particularly those outcomes, at the center, and the costs to achieve those outcomes across the entire continuum of care. So that is the opportunity that value-based healthcare presents, because it then forces everybody to think in a slightly different way about things that matter to the people, as someone said earlier, who should be the clients, the customers, the point of the health system in the first place, and gets people thinking about things in that more integrated fashion. So just want to bring it back to that slide for our consideration before we go on break. So thank you so much, guys, for going a bit over. Let's take 10 minutes and reconvene at about 23, 25 or so. I'll start talking to you to try to get you back together. Thank you.